Today's discussion is a continuation of the previous Demystifying Medicine seminar, Salt in My Soul and Unfinished Life. For our viewers that do not know, Salt in My Soul is the memoir of Mallory Smith, a young woman who fought bravely against cystic fibrosis, but ultimately lost her battle to this chronic illness. In our first seminar, Mallory's mother, Diane Shader Smith, spoke to us about the memoir, the struggles that cystic fibrosis patients like Mallory face, as well as systemic issues in healthcare and in the treatment of chronic or life-threatening illnesses. During her talk, Diane discussed an experimental treatment that Mallory received in the final stages of her life. This treatment, called bacteriophage therapy, was used as a last resort to fight against an infection of the bacteria Phage in Mallory's body. After her passing, it was confirmed that the bacteriophages had started to successfully fight the infection. In our video, we will be exploring this topic of phage therapy and how it can be used in the battle against life-threatening illnesses such as cystic fibrosis. Today, we are pleased to speak with Mallory's father, Mark Smith, who is also a lawyer and an advocate for cystic fibrosis and phage therapy. Thank you for speaking with us today, Mark.
Thank you for having me on. I'm happy to be here. Phage therapy is the use of phages, or bacteriophages, as they are also called, to kill bacteria. Phages are a kind of virus. A virus evolved to attack bacteria. They don't attack human cells. So they're relatively safe to put in someone's body, and they can phages can often be found that will kill bacteria that don't respond to antibiotics.
Okay.
In general, it's used in Russia now to treat dysentery. And they do that by taking an oral phage solution. It goes into the intestinal tract. But in the West, we generally use antibiotics for diseases like that. And the overuse of antibiotics in medicine and in agriculture has led to a growing problem of multiple resistant strains of bacteria, also called superbugs. And these superbugs are everywhere, especially in hospitals. And phage therapy is generally thought to be an effective way to eradicate superbug infections in patients. The funny thing about cystic fibrosis is, not funny, remarkable, is people don't die from cystic fibrosis itself. You die from the damage to the lungs that is caused by recurrent bacterial infections. Ordinary lungs clear bacteria out effectively. So even though you breathe bacteria in every day, your body sweeps them back out and you kind of go, and they're gone from your lungs. In cystic fibrosis, the mucus in the lungs becomes salty and sticky and difficult to clear. And it also loses its antibacterial component because the antibacterial element in the lung mucus is deactivated by high salt concentrations. So typically what happens is a cystic fibrosis patient will get this mucus buildup, and then they inhale bacteria, and the bacteria stay and infect the lungs instead of getting swept out. When this happens, the patient is given inhaled antibiotics, and when there's a flare-up, they get intravenous antibiotics. But because of the complicated architecture of the lungs, we're never able to completely eradicate the infection. So we treat it with antibiotics and kill 99% of the germs, but the 1% that's left there is more resistant to antibiotics. And over the course of a patient's life, suppressing bacterial infections over and over again, and having them grow back up, breeds a superbug. Whatever germ they start out with, Bisapatia, Pseudomonas, staph, the treatment process causes the germs to evolve into a superbug. So ultimately, the germs cause so much damage that the lungs can barely breathe anymore, and then you die from a pneumonia from that bug or something. So every cystic fibrosis patient ultimately will get a superbug, even if they didn't start out with a superbug. If they started out with an ordinary bacterium that you find in the kitchen or in the garden, the treatment process causes it to evolve into a superbug. So it's every cystic fibrosis patient, and that's why I thought phage therapy could be directed towards cystic fibrosis patients very effectively. Well, I had tried to get phage therapy for Mallory before she got her lung transplant. And I was trying then because all the hospitals, the lung transplant centers said they wouldn't transplant someone with Mallory's germ. And the reason they don't transplant people with Bisapatia infections is the Bisapatia lives in the lungs and also in the sinuses. So what happens when you do a transplant, you take the lungs out, you put new lungs in. The new lungs don't have cystic fibrosis. So in theory, they should be able to clear bacterial infections well. But the immunosuppressants that they give to prevent rejection makes the lungs vulnerable to reinfection. And the reservoir of Bisapatia germs in the sinuses goes in and infects the new lungs. So they don't want to waste lungs on a patient who's probably not going to live very long. Lungs are a very scarce resource in the transplant world. So I looked into getting phage therapy first to clear her Bisapatia infection so that she'd be eligible for transplant. I didn't get any traction on that. Ultimately, she was accepted at UPMC for transplant, and she had a successful lung transplant and was out of the hospital and home and walking and participating in the activities of daily life without being tethered to an oxygen tank. And then a month or so after the transplant, she started getting pneumonia from the Bisapatia. And at that stage, I knew that the only thing that would save her was a novel therapy. The antibiotics would not combat her bacteria at all. So I started my research up again, and I found that there had been one case where a man in San Diego had been treated with phage therapy for a multiply resistant superbug infection in his pancreas. And I reached out to his medical team, and they helped me put together an international search for phages that would attack Mallory's organism. Each variety of phage is specific to a species or a strain of bacteria. They're very target specific, which, by the way, is an advantage of them because they don't kill the good gut bacteria that we need to live. So we hunted down, we sent sputum samples all over the world to researchers who tested their phage samples against Mallory's organism. And we found 2 varieties of phage that would kill it. And we had them shipped to a facility in Maryland to be multiplied and purified. The way they multiply them is they take a jug of, let's say, chicken soup, of stuff that bacteria like to eat, and they infect it with the bacteria so that the bacteria multiply and multiply and multiply until you have a whole big flask that is cloudy and green because of the bacteria. After you've done that, you got a whole flask full of bacteria. You drop in the phage, and the phage kills off the bacteria and multiplies, and the murky green color goes away, and you have a flask of clear fluid. And that clear fluid contains trillions of phages and a whole bunch of bacteria guts, which you have to filter out. And then all this, growing the sputum culture up, growing multiplying the phages, and then purifying them so they can be used in the body. Those all take time, and there's no way to rush them. We tried to rush things along by having the teams work 24 hours a day, 7 days a week, and by using overnight delivery every time we needed to move something from one place to another. Not everybody cooperated completely, and sometimes people would send things by 2-day overnight. So we probably lost a couple of days, but ultimately we got the 2 phages purified enough to put into Mallory's lungs, and we airlifted them from Maryland by plane to a local county airport in Pittsburgh, and then they were airlifted by helicopter to the hospital, and they put them in Mallory's lungs at 6 o'clock on the 14th of November, and then 6 o'clock p.m. And then the next morning we were getting ready to administer the second round of doses, and the doctors told us that Mallory had been without enough blood oxygen for so long that even if we pulled her back from the brink of death, she would have suffered irreparable brain damage. So we discontinued the phages and pulled the plug on her life support, and she died later that afternoon. Then the autopsy revealed that the phages had reached the site of the infection and had started to multiply and kill the germs. So I didn't mention before about in phage therapy that one of the great things about it is when a phage kills a bacterium, it doesn't just take one phage and kill one bacterium. It takes one phage, it kills one bacterium, and then that dead bacterium releases scores or maybe hundreds, depending on the variety, of new phage particles that can go out and kill other ones. So it's a little bit like a nuclear chain reaction, which makes phage therapy somewhat not dose dependent the way antibiotics are. So we were very happy to learn that the phages had started to work, but alas, Mallory had gotten them probably 3 or 4 days too late. And they may have saved her life if we had gotten them to her earlier, or they may not. We just don't know.
Mm-hmm.
The main obstacle was that none of the doctors knew what it was. Not even the chairman of the Department of Infectious Diseases had heard of phage therapy. And so we had to educate our doctor team about what it was before they would give us the go-ahead. At this stage, though, it was pretty clear that Mallory only had a couple of days to live. And even if the phage therapy killed her, it was worth trying. So the doctors agreed to work with us, and then we had to overcome regulatory hurdles. You're not allowed to give therapies that haven't been approved by the FDA to live patients in hospitals. But there is a procedure for EIND, emergency, I think it stands for emergency investigational new drug. But basically what it means is the patient is going to die if we don't try this. So please let us try this. And the FDA allows those uses if they're documented accurately enough. And so we had our team from UPMC and the team from San Diego that had treated the previous patient. So they knew the right person to talk to at the FDA to get the approval. And they knew the right argument because it had worked for the patient one. And we got the approval, and that did not slow us down. The only thing that really slowed us down was the finding the phages and then growing them and multiplying them and purifying them. Those took the time. The FDA was very cooperative, and we had the right team to persuade them. Well, after Mallory died, I had this idea that cystic fibrosis patients could be treated very early in their life with phage therapy, and it might be possible to eradicate their lung infections, not just to suppress them the way antibiotic therapy does. That phage therapy, or maybe even a combination of phage therapy and antibiotic therapy, might enable young cystic fibrosis patients to clear their infection completely. And if they could clear their infection completely, then they wouldn't suffer the gradual deterioration of lung function. And cystic fibrosis might become a maintenance disease where you had to periodically have phage therapy and do percussion, airway clearance, but people wouldn't die from it anymore. And I was very keen on that, and I tried to get the Cystic Fibrosis Foundation interested. And I got them a little bit interested, not a whole bunch, but a little bit. They're very keen on funding projects that will return money to them in excess of the money that they spend. So they're supposed to be a nonprofit, and I suppose they technically are a nonprofit, but they like to get a return on their investment so they can fund more projects. Meantime, I met a woman who had received phage therapy at Yale University. And so I went to Yale and I met with the doctors there who were doing phage therapy just like what we had done for Mallory, but on CF patients, some of them who were post-transplant, and the one that I met was pre-transplant. She couldn't get on the transplant list anywhere. And then Yale gave her a course of phage therapy and cleared her infection sufficiently, so she's on the transplant list now. So I went and met with the doctors at Yale, and I participated in a couple of patients administering the phage therapy. I participated in collecting the phages from the environment and growing them and multiplying them and purifying them. So I became pretty familiar with all the different stages of the process. It's not terribly difficult, and it's not terribly costly. I think, for a couple of $100, you might be able to treat a cystic fibrosis patient and get rid of their infection, which would be a tremendous boon to, certainly to health insurance companies who pay for the medical care. But it doesn't generate any royalties. And so the difficulty is finding someone willing to pay millions of dollars to do a placebo-controlled, double-blind phase 1 test to prove the safety and efficacy of phage therapy. And so far, no one's really been willing to do that. It would have to be maybe the government or a charity that was not concerned about return on investment. And that's kind of where we left it. And I haven't been doing an awful lot recently except speaking. I still think that phage therapy has a wonderful home in the cystic fibrosis community. But ultimately, it's going to save millions of lives as the superbug crisis continues to escalate. Well, someone would have to spend maybe $5, maybe $10 million on a study that was conducted according to FDA protocols, including a placebo control group. It would have to be multi-site, and a program like that might end up with an approval for phage therapy for that specific population, for cystic fibrosis patients. And that would be a great first step. There are some people that are working on clinical trials now. The IPATH Center in San Diego is working on one, and I think the Yale team also is pursuing a clinical trial with the double-blind controls and the placebos and everything. So it's starting to happen, but somebody has to be willing to pay for that funding that isn't going to be able to earn a lot of revenues out of it. Mm-hmm. Phage therapy has the potential to save millions and millions of lives, and it needs to be studied. So donate money to it. Encourage the government to fund it. Let's get it out of the lab and into the clinic so we can start saving